The work I'm doing with them is helping them on the cost control side of the equation. They have worked on legislation that will give people access to health care and that will make sure and access to health insurance, and will make certain that the health insurance people have access to gives them the kind of coverage that they should have. But there's a lot of work yet to be done on how do we actually manage health care so the health care costs are more reasonable. To reduce costs and to improve quality, to me it's crucially important to get the patients more involved and feeling more responsible about their health care, and also to provide a set of incentives for doctors so that the system provides the kind of support people need. We basically have an episodic care system where it's like a muffler shop where you have something wrong, you go in and you get it fixed. But lots and lots of folks now we have an aging population, and our aging over 65 group's getting larger and larger, and they need a lot of support. So someone recently diagnosed as a diabetic needs real help in terms of how they should live their life in order to not have complications related to diabetes. And what I've been working on the last decade is material and programs and ideas related to giving patients the tools they need and doctors the tools they need in order to have patients more involved and in order to have doctors more reasonably compensated for the longitudinal support kind of activities. So the two big ideas are appropriate incentives and motivation for individuals and appropriate incentives and motivation for physicians. And there's been provision in the current legislation. They've set aside a few $1 billion for an innovation center to pursue ideas related to those topics, but they've not yet been incorporated in a major way in the legislation that, if any, is passed. They're not in any legislation that would be passed in the near term, but they will pass legislation that will do further research to include ideas like that in the future. I think that physician incentives and the way, in fact, we pay physicians it needs fixed. Until we do, it's very hard to control the cost. There's a lot of discussion about tort law too, about not having to practice preventive medicine or legally defensive medicine. But if physicians are paid for activities and not paid for keeping people healthy, and until we get the incentive system aligned, it is very, very difficult for a person to make a living practicing as a physician when all the compensation relates to things they do rather than things they talk about or incentives they provide. And we have many, many gifted and talented physicians who do a lot of that in spite of the fact the system is warped and not well organized in that regard. But the system will benefit enormously if we find ways to pay physicians for prophylactic care to help individuals be motivated and to do the things so they don't get serious diseases, and if they have the serious diseases, to motivate them to do the common sense things they should do and to do the things that their doctors recommend. So there's huge opportunity. As much as a third of healthcare expenditures, my experts suggest, could be reduced if in fact we were better at motivating people to be more involved and incented doctors so they could provide the kind of care a lot of people need. I think what the government should do is set the examples through their activities in Medicare and Medicaid related to paying physicians properly and related to getting people motivated. So I think they should use the Medicare and Medicaid vehicles to demonstrate those things. Then I think the government needs to play referee. The big debate seems to be where there are those that argue that free market forces in healthcare would yield decent solutions, the way free market forces do in other parts of the economy. The problem is there's an asymmetry of information in the medical field, meaning that if you have a sore back and a doctor says you need surgery, the patient really doesn't have the information to know if there's another alternative. That asymmetry of information means that left to run wild. Market forces, in fact, don't always arrive at a solution that makes sense, at least through my prism. The other side argues that the government doesn't have a perfect record at managing things, and that having them play too active a role is not consistent with, in their view, in the American way. The answer, I think, is for the government to be a rational referee, and it is possible to find common ground. What they need, in my view, is we need to recognize that left to its own devices, free market forces will not yield a perfect healthcare system. And we can honor those who think that we shouldn't necessarily have the government do it all. If, in fact, the government could play rational referee, which I think they can, and I work with both sides trying to help them find that common ground, if we can be a legitimate referee as a federal government, we can make healthcare work. And it can be much cheaper than it is now. It's a simple idea and a common sense idea. A lot of times we view the clinical problem as diagnosing what ails the person and prescribing medication or surgery or some other therapy to address it. The problem is the person comes as a package of things. And if the person is depressed, that acknowledging that they have diabetes and knowing they should take their insulin doesn't solve the problem. If the person doesn't get over their depression, they may not care if they get more seriously ill. So you got to treat them as a whole person related to both their mental health and their physical health. If a mother has a very sick child, but the mother herself has diabetes and the child has diabetes, if the mother is so worried in caring for the child that she doesn't take care of herself, her health deteriorates. And so those of us that supply support, in my view, need to take into account the economic circumstances, the family circumstances, the mental health circumstances that surround the person, and treat them as a whole person. And that's the whole person idea, to treat them for all the dimensions of their life and to provide them support so that they can do the clinical things they should do, but to not be so oversimplified to pretend like knowing what disease they have and knowing what medication they should take ends the responsibility of the clinical system. That's an area where I've had lots and lots of exposure. I work with a group out of Dartmouth that has documented enormous disparities in healthcare in the country. If you have a herniated disc and live in San Francisco, you are about 6 times more likely to have it treated surgically than if you live in many East Coast cities. And about 3 times more likely to have your spine fused than if you live on the East Coast. So I work with a group of academics that have documented those wide disparities. And there are disparities relative to rates of open heart surgery, relative to treatments for prostate cancer, breast cancer, of those same magnitudes. The answer, in my view, is information dissemination. Same way the Surgeon General made smoking a big issue and had it in all the newspapers and on all the TVs. We just need to document the fact that those disparities exist, make the physicians aware of it, make the patients aware of it, and then supply both those groups with information so they can help sort out what is probably the appropriate rate. The little bit of research that has been done on are the ones getting a lot getting too much or the ones getting less getting too little suggests, and this is academic research that I've had access to, it indicates that in most cases the ones that are getting a lot are getting too much, not that the ones that are getting a little less are getting too little. And so the way to address the disparities is to make it known and then supply both groups with tools and information so that they can better select for individual patients what the appropriate things to do are. It's very intimidating for people to understand the information surrounding a lot of health issues. And a lot of them aren't aware that if you're on the West Coast, you're more likely to have surgery. It is as simple as giving people information and confidence. So I actually, in the most recent firm, and the firm I'm still chairman of, the most recent firm I formed and the one I'm chairman of, We have nurses who provide telephonic support to people. And one of the most meaningful things that those nurses do is help the individuals prepare 3 questions for their physicians. The nurses never diagnose, they never recommend treatment. Their entire role is to help the patients understand their condition and understand, in most cases, what the options are for treatment and to understand the benefits and risks of those. We have videotapes and web modules and other devices so the nurse can help the patient understand the trade-offs, and then the nurse works with the patient telephonically to help form 3 questions. And those 3 questions are very helpful to the doctor and very helpful to the patient. Picture that if a patient comes into a doctor with 15 articles off the web and says, "Doc, I think articles 3, 7, and 9 apply to me. What do you think?" That can be an endless morass for a doctor. If the patient comes in with 3 well-articulated questions that were developed by someone who did not have a point of view about what the patient ought to do, only wanting to help the patient understand trade-offs, very powerful for the doctor, very efficient for the doctor, and great for the patient. So the way to get the patient's voice heard, in my view, is not megaphones on top soapboxes on street corners. The way to get the patient's views heard is to supply them with support and help them form 3 questions. They do need some vetting process. So the way we help them is to make sure they go to sites, if it's a web-based support, source of information, that they go to sites where the information is objective and not self-serving and not put out by a group that doesn't necessarily have the patient's best interests at heart. So what these nurses do is provide lists to the patients of places to go that can be trusted, and then supply objective commentary around those sites. But it is true they have greater access, but we have to be careful that there's some vetting, and so that the people go to sites that are objective and fair and have their best interests at heart. Some folks want the free market to do it. Other folks think that having it more centralized where the government could control it would be a better solution. That's why and that same point of view separates our great nation on other issues as well. My own view in healthcare, where I have tried to straddle this, I've worked on both sides of the political aisle, I'm working hard to help them find common ground, is to admit that the free market forces left their own devices will not solve the problem. And you can still have the debate about how much the government can do, but at a minimum the government should be a rational referee there, and should help set up incentives and provide information and support that lets the patients get more involved. So I do think the reason it's so volatile, there's different views on the on how you approach it, and I view there's common ground, and it says use as much of the free market forces as you can, but have a government set of refereeing that relates to incentives and information dissemination as you can. Find Waldo. It ends up, I worked with chief executives and boards of directors and senior executives all over the United States and Western Europe for several decades. And I was often asked what made an effective executive. How did I identify those? And as I reflected back, I discovered that the single most discriminating characteristic of executives that appeared to be effective was the skill with which they decided what not to do. And that's a little bit counterintuitive. But that's the strength that I've found. People have to be moderately skillful at what they decide to do, but it's screening out the infinite things contending for your time, money, and attention that is the powerful skill. And the Where's Waldo metaphor is a wonderful metaphor for talking about that subject. Waldo is symbolic of the elusive relevant. That's the child's game with all the confusing detail with Waldo stuck. But the fascinating part is, if you find Waldo, then he's obvious, but it's not easy to find him. I also point out that even if you can point to the area of the picture where Waldo is, he's still hard to find. So it's a wonderful metaphor in that it says the background noise in a Where's Waldo exercise is symbolic of the things contending for our time management and attention. Waldo is symbolic of the elusive relevant, the 1, 2, or 3 things that actually make a difference and are the things that a good executive and his or her team should do. So the advice I have is spend some time finding Waldo instead of wandering in the confusion of the background data that surrounds Waldo. Among the things that I remember most fondly is the director of the placement office here at the university. It was a woman named Cornelia Ladvig. She was here when I was here. And I was trying to find a summer job. She spent several hours with me learning about some things I could do, including the fact I'd worked as a programmer, computer programmer at the computer center, and had taken some computer courses. But she said, I can't get a summer job for you because they only give summer jobs to juniors and sophomores and juniors, never to freshmen. And I was looking for a job after my freshman year. But she said she'd see what she could do. And the next day, she came in and said, the Ford Motor Company, in fact, will give you a summer job. And I met the recruiter, and he came in and said, yeah, I have a place in the transmission and chassis division up in Livonia, Michigan, and you can have it. And I was thrilled. And at the time, I was convinced that it was the skill with which I had written my resume. And I later learned that, in fact, Cornelia Ladvig at the time was dating the Ford Motor Company recruiter, and in fact had asked him if, in fact, he would make an exception and take me as a freshman. So the big lesson learned was that serendipity counts too. I think I was very lucky, and I am and will be forever grateful for Cornelia Ladvig, because she got me one of the greatest summer jobs any freshman ever got.